Can food is medicine become a reality in mainstream medicine? Find out here today on Jimmy Rants. Click on that little box down there in the corner. It'll take you straight to IGTV for today's episode. JimmyRants.com is the website, and as always, you can engage live in the content. You got to go follow me over on Instagram. I'm at Living Low Carb Man, LivinLowCarbman. Once you're there, engage live. We are here Monday through Friday, 11 a.m. Eastern Time, right here on Instagram Live. And even if you don't get a notification, just know I'm right here. So go to my page at Living Low Carb Man and just click on my picture, and it'll take you straight to this IGTV at 11 a.m. Eastern Time, Monday through Friday. We also simulcast over here on my Facebook page. So thank you guys for being here. Thank you for popping in, Tanya. I just saw you just came in. And finally, over here on my YouTube channel, appreciate you guys watching as well. Got my whole Jimmy Rants family here today. Thank you all for being here. If you missed the live, we do put it up on replay on IGTV. Got a lot of people that watch this on IGTV when it's over, so thank you if that's you watching this on replay. Really love doing this show for you guys as well, because I know 11 a.m. Eastern isn't always convenient for everyone, but you can definitely watch it on demand on IGTV. We also put it on demand over at YouTube. Just type in a keyword, Jimmy Rants. You will find the show. It is Tuesday, so on Tuesdays I have a best of Jimmy Rants that airs on the Livin' La Vida Low Carb show. So go over there today, llvlc.com, and you can see one of the best of, or basically listen to one of the best of this podcast, or that we do here every day on that podcast. And then finally, go over to jimmyrants.com, and when you're there, you can see all the past episodes, and you can support me through the Patreon. Click on the link, and it'll let you donate any amount. But for those of you that have already donated to the Patreon, or if you're interested in it, you will be interested to know that I am giving you a few new perks now. I'm giving you early access to my podcast for the upcoming week. So both of my podcast interviews that are going to air Wednesday and Thursday are already up for you guys on the Patreon page. So go check out that Patreon link at jimmyrants.com. I'm also going to be doing some exclusive Jimmy Rants content just for my Patreons. And so if you sign up, there will be fresh Jimmy Rants that you won't see anywhere else. So get ready for that. That's coming very soon as well. And then I'm going to let you help be part of my production team of editorial, telling me which direction you want me to go with some of the content. I have a ton of things I always have to talk about, at least 25 things I've printed out that I'm ready to talk about. So I'm going to get your input as to what you want me to talk about on this here show. Sometimes things fall by the wayside because I have so many things to talk about. So if you want to kind of get in on the action, again, click on that Patreon link at jimmyrants.com, and you can be one of my supporters. And of course, it helps me out financially right now. So, all right, you guys. So one of the major concepts that I've been about ever since I've been online is that we need to be looking at food in a much deeper way than we already are. Because currently people just see food as a recreational thing. They see food as something that feels good when they eat it, that tastes good. They only see food in a very monolithic way. And of course, those of us that have changed our lives, that have been able to cut our carbs and eat real food and see profound changes in our health as a result of those changes in our nutrition, we already view food as medicine, right? So we realize that there's certain metabolic healing that takes place when you cut down on processed foods, what I call crappy garbage, food like disease agents, and when you add in real whole food based fats and proteins and just real food. And this concept of food as medicine, it's amazing to me that we have to explain that food would be medicine, because the basic building blocks of everything that goes on in your body all comes from food. Think about amino acids. They are the basic building blocks of almost everything in your body, from muscles to cell, everything And then fats, that's why you have essential amino acids. You got essential fatty acids. They're essential, meaning you can't make them in your own body. You have to consume them to get them in your body. By the way, there is no essential carbohydrate acid. It just doesn't exist. It doesn't. Doesn't mean you can't eat carbs. It just means there's no nutritional reason for you to be consuming carbs. The body doesn't require it because your body can make all the carbs it needs. But you do get some properties, fiber, various micronutrients if you choose to eat vegetables, for example. But don't think that you have to have carbs, because you really don't. But you do have to have fat and protein. But going back to the food as medicine. So this is such an elementary concept that you would think anybody in the medical professional health space would be getting massive amounts of education when it comes to nutrition. And people are so shocked when I reveal to them that the amount of time that a medical professional, specifically doctors, get in nutrition education is so minuscule, it's an afterthought. I've interviewed many people over the years on the Living La Vida Low Carb show that are in the medical profession. They're MDs, they're DOs, and they're in that profession. And I almost invariably ask all of them the same question. How much education did you get in nutrition? I've had as much as 1 week. That was other than a naturopath. Obviously, a naturopath gets a lot more than that. But a traditionally trained medical doctor, 1 week was the longest I've ever heard, to like a 3 days worth of classes to a 3-hour seminar. I've literally heard the gamut. And most of the time when they focus on nutrition, it's not even on like the insulin effects that come from consuming carbohydrates and that kind of, nothing like that. It's all basically the food guide pyramid, the dietary guidelines. And so are they really learning? So the concept of food as medicine is catching on though, guys. And I found this editorial in the British Medical Journal. And again, if you're not reading the British Medical Journal, they're doing some fantastic work. And recently, this year, during COVID-19, they decided they had this idea. Let's reach out to some researchers that have published previous research, and let's ask them to join this Food for Thought series. So they've got this Food for Thought series. I think I did another Jimmy Rants on one of their Food for Thought articles previously. But this one here today is so important. If you care about health, and those of you that follow my work, you do personally care about your own health, but you want to see your friends, your family, the people out there getting the benefits that you got, vis-a-vis weight loss, vis-a-vis health improvements, all the things. And the only way that's going to happen is if they get reinforcement of it at their doctor's office. And so the title of this Food for Thought analysis is Food is Medicine: Actions to Integrate Food and Nutrition into Healthcare. This was just published June the 29th, 2020. And it's from Sarah Downer, a clinical instructor, Seth Berkowitz, an assistant professor, Tim Harlan, associate professor, Dana Olstad, an assistant professor, and then Dariush Mosafarian is the dean of the school. So I know Dariush's work. He's done some work on breakfast, various times. If you eat enough calories at breakfast, you don't eat as many calories later, and so I'm familiar with this department, but it's really fascinating to me. Oh, and they're at Harvard University, by the way. It's really fascinating that the things they're going to articulate in this paper that I'm going to share here today. Why isn't this already happening? Like, it's amazing we got so far down this rabbit hole that health care and chronic disease is out of control. But it took COVID-19 to put this on their radar screen. Oh my gosh, we had no idea. Yeah, we did. We've known about this for a little while. But if COVID was the thing that got it on their radar screen to get them to write an article like this that maybe will penetrate the culture that people will start taking this more seriously, then okay, great. but making food is medicine a reality in mainstream healthcare is a must, and they make that case in here. All right, let me read this. If you just joined us, we are reading from a British medical journal analysis from their series called Food for Thought. They've been doing that in 2020. This one's called Food is Medicine, Actions to Integrate Food and Nutrition into Healthcare. So if you're in the healthcare profession, or if you know somebody in the healthcare profession, tell them about this because it's really fascinating stuff. In the face of the global epidemic of diet-related chronic disease, there is increased experimentation with the use of food is medicine interventions to prevent, manage, and treat illness. Interventions used with increasing frequency in the U.S. and piloted to some extent in other countries include medically tailored meals. In other words, you have this X disease, so here are meal plans that will help you with X disease. Now, sometimes those medically tailored plans aren't necessarily the greatest for that condition, but let's put that aside for the moment. Medically tailored groceries along the same concept, and produce prescription programs. In other words, okay, you've got X disease, here is a prescription for you to go buy, a bunch of vegetables. Scaled integration of these and other emerging nutrition interventions into healthcare would require significant investment in rigorous research to test different approaches and address those knowledge gaps. We do need the research, and that's one of the points that they put in this paper, you guys, is the way you integrate this into healthcare is you show the data. Because a lot of healthcare professionals, they want to see the science that supports this. Do you have sound research that shows a nutritional modality is going to work better than the pharmaceutical? And if you do, and God forbid, oh my gosh, the nutritional therapy works better than the drug therapy, all the more reason we need to have that research. Clinicians need more and better education on the training on the appropriateness of these interventions. Right now, they're getting next to nil training and education when it comes to nutrition. We also need to identify sustained funding streams to ensure equitable access and availability for patients. They go into great detail about that here in a minute. A global epidemic of diet-related chronic disease has prompted experimentation using food as a formal part of the patient care and treatment. 1 out of every 5 deaths across the globe is attributable to a suboptimal diet. Did you get that? 20% of people die because their diet sucks. And more than any other risk factor, including tobacco. That's shocking, right? Individual interactions with the healthcare system are an important opportunity to offer evidence-based food and nutrition interventions. An emerging but compelling body of research indicates that such interventions delivered in the healthcare system might be associated with improved health outcomes and reduced healthcare usage and costs. Well, that makes sense. When people get sick, they don't go see a dietitian. When people get sick, they don't go see a functional medicine practitioner. When people get sick, they don't first think of diet. They first think of doctor. And so if you first think of doctor and you go to the doctor and he's been trained in pharmacology and physiology, do you think he's going to know how to change your diet to fix whatever it is wrong with you? No. This is what's broken about the healthcare system. We have a bunch of people being put on medications that are hiding the effects of the nutrient deficiencies that a good, solid diet would actually help to fix. And a lot of the chronic conditions that people deal with on a daily basis is not a deficiency in whatever drug that doctor puts you on. It's a deficiency in good, healthy nutrition. We are malnourished to the hilt. All those foods that you consume aren't just blobs of delicious morsels. They actually give you nourishment. Amino acids, fatty acids, vitamins, minerals, fiber. All of these things essential to the human diet, which is essential to your body functioning at its highest level. And we seem to forget that that is the purpose of what food is. And so it makes sense that you would want to integrate nutrition into the curriculum of these medical professionals. These data point to the potential for food and nutrition interventions to play a prominent role in the prevention, management, treatment, and even in some cases, reversal of disease. We see type 2 diabetes reversed all the time. You cut people's carbs, it lowers their dependence and need for controlling blood sugars with insulin. They lower the level of medications that they take, and it naturally heals itself. And all you did was manipulate the diet. When broadly deployed, interventions that are effective for individual patients have the potential to affect population health and to shape broader food and health policy reform. Realization of health benefits is, however, hampered by a lack of investment in research. That's a biggie, guys. Most of the investments in nutritional health research come from industry or from private donors. So a lot of the low carb research, the ketogenic research, if it wasn't for billionaires that had these funds that they set up to help fund it, a lot of those studies would never happen. The NIH just has been derelict in giving funds for researching ketogenic diets. Now it's a little better than it used to be. It's starting to change, but traditionally they have not been very good at vetting out some of these concepts when it comes to nutrition and its effect on your health. And so that's kind of hampered a lot of this as well. So low investment in research is a big problem. Low level of clinician nutrition knowledge and awareness of interventions. You go talk to your doctor about keto, he's going to go, "Key what?" And I know I've heard from people all the time. They write to me. I go to talk to my doctor about ketosis, and he's talking about how dangerous it is. I'm like, "Did you explain it was nutritional ketosis and not ketoacidosis?" "Well, no, they just kept talking about ketosis being dangerous." I said, "Well, they're referring to ketoacidosis. You know from reading books like my book, Keto Clarity, you know that there is a huge difference between those. The problem is that's what the doctor knows about ketones is it's a very bad thing. It means bad metabolic things are going on in the body, and they're not understanding it in the context of carbohydrate restriction being a very good thing, and that metabolically you're in a much better place for lower inflammation and insulin and blood sugar and all the rest." So clinician knowledge and awareness is not there. And narrow access to appropriate services and programs. And again, this is a problem when patients come in and they want to have a good, healthy nutrition plan. There's really nowhere for these doctors to send them right now. Tackling each of these challenges is critical to achieving a healthcare system in which nutrition and food are a routine part of evidence-based disease prevention and treatment. I love that they called it evidence-based disease prevention and treatment, because you can put anybody on a diet, but if you've got evidence that supports it through research and studies and even like case studies with a doctor, it makes a huge difference. We argue for increased integration of specific food and nutrition interventions in or closely coordinated with the healthcare system. We call this initiative Food is Medicine. We focus on novel interventions such as the medically tailored meals I was talking about and prescriptions for produce that incorporate food strategies to improve health in the structure and funding of the healthcare system rather than traditional medical nutrition interventions such as those focusing on vitamin or other nutrition supplements or medical foods. Yeah, it's so funny, like when you have a vitamin C deficiency, is anybody telling you to go eat foods that contain lots of vitamin C? No. In the mainstream medical field, if you have a vitamin C deficiency, they give you vitamin C to take. That's prescription. Same with vitamin D. If you've got a vitamin D deficiency, they will put you on vitamin D2 as a prescription. It's a 50,000 IU prescription. And it's ineffective, by the way. If you're going to get vitamin D, number one, get it from the sun. No doctor's telling you go in the sun, but they'll have a 50,000 IU of a vitamin D2 that your body doesn't know what to do with. You're much better off if you're going to supplement to go to the store and get vitamin D3 gel caps and then mix it with some K2, and you're going to get a whole lot better bang for your buck. But see, the doctors don't know that either. But that's what they do. They're in this stuck in the old mentality, old modality of how they do things, and they stick to that template. And what they're arguing in this piece is they got to start learning that food is medicine. All right. Food is medicine interventions include medically tailored meals, also called therapeutic meals, medically tailored groceries, sometimes known as pharmacies, Pharmacies, or healthy food prescriptions, and produce prescriptions. They are typically directed by clinicians through the healthcare system. They're provided at no cost or very low cost to the patient, funded by healthcare, government, and philanthropy. Through a PubMed database research and by polling our network of international colleagues, we found 32 studies in the literature that evaluated food is medicine as an intervention. Most of the examples that we found were in the US, a few of them in Australia, Canada, and the UK. We found none in Brazil, Finland, Germany, Ireland, or Mexico. Most interventions were dependent of any philanthropy rather organizational or institutional support instead. Reflecting the relative novelty of these efforts, data on the health impact of food as medicine programs were widely variable in the peer-reviewed literature. All of these interventions vary widely in intensity and breadth of patient coverage. Medically tailored meals are the highest intensity intervention necessary for a small but high needs group, those who have very complex medical conditions and are unable to shop or prepare. So that is something that I've noticed a few companies have stepped up in. You have diabetes, great. We've got the perfect medically tailored diabetes meal plans for you. Now, the problem with that is some of them will be the traditional low-fat, high-grain diabetes diet, and then some of them actually incorporate more of a lower-carb, higher-fat form of diabetes control. So when you look at these medical interventions, they need to be looking at what does the patient want to do, because if you choose to do the traditional ADA, the old way of ADA with a low-fat, high-grain type of diet for diabetes, it's going to be a far cry from what a lot of people are doing, and even the ADA has switched maybe to more of a low-carb plan. Maybe you want to try that. So you got to be sure that just because it says diabetes diet with the meal plan, that it's indeed for diabetes. Over the past 3 years, the U.S. has launched multiple large medically tailored meal projects for this population in their public insurance program, additional use for elderly people. The research on medically tailored meals cited in this article includes larger sample populations and more robust research design than for other inventions. In a retrospective cohort study of 1,020 participants, receipt of medically tailored meals was associated with a 16% net reduction in overall healthcare costs, 49 fewer inpatient hospital admissions, and 72% fewer admissions into skilled nursing facilities compared with the controlled group. And here is the biggest reason this concept of food is medicine needs to be embraced a whole lot more. Look at the out of control costs associated with dealing with even just type 2 diabetes. Hundreds of billions of dollars a year. And then you look at cardiovascular disease, same thing. Hundreds of billions of dollars a year. Obesity, hundreds of billions of dollars a year. On and on and on. All this wasted money in the healthcare system, all because doctors don't know enough about nutrition. And it's time to buck up. It's time to learn. It's time for medical schools to get on board and realize this is why medicine's falling apart in the traditional way. We need a new way. This is why functional medicine has come on strong. This is why people trust naturopaths a whole lot more than they do mainstream medical doctors, because quite frankly, most of the mainstream medical doctors have dropped the ball. There's some that have learned, and in our keto space, there's great ones that are out there, keto and carnivore, that are promoting food as medicine now, but there's still a huge minority of the general mainstream medical profession. Medically tailored groceries are appropriate for a broad number of patients, those with diet-related chronic and acute conditions, but who can cook and prepare at home. So yeah, they talk about that just like they did the medically tailored meals. Produce prescriptions are appropriate for the broadest number of recipients, both for disease prevention and management. Several studies looked at those programs and how people's consumptions of things like fruits and vegetables, but the clinical outcomes and claims are relatively recent. Research on the intervention is trending in recent years towards a more robust study design. Modeling studies indicate prescriptions for a wide array of healthful foods can be a highly cost-effective and even cost-saving for the healthcare system. But the problem is, when you start looking at a wide array of healthful foods, who gets to decide what is a healthful food and what is not a healthful food? Especially with all the negativity that's put out there about red meat. What if someone chooses that they want to go on a carnivore diet to control their diabetes, for example, and they want to eat an all red meat diet? They just want to eat that. Would that be included in cost savings, a healthful array of foods? To a carnivore, yeah. But who gets to define what an array of healthful foods is? This is part of the discussion they need to be having with food as medicine. We can't say X food is bad when someone else says X food is good. Who's going to rule that? But the problem becomes when you start talking about funding for patients with a said condition, giving them a said diet. It's going to get muddied there, and that's going to be the next line. If they actually start to implement food as medicine, they need to start talking about these things of defining what a good healthy food is for X condition. And of course, we would argue if someone with type 2 diabetes, they need to be eliminating carbohydrates and eating more animal foods, proteins and fats primarily. And so that's going to be an interesting conversation. Researchers in the U.S. found that over a lifetime, a 30% subsidy incentive on fruits and vegetables would prevent nearly 2 million cardiovascular disease events and save $40 billion. Those are all based on models, and I'm sure there would be benefit, because when you take people off of junk food and you put them on fruits and vegetables, obviously they're going to see a benefit, not by what they added, but by what they took away. So when they kind of do this, fruits and vegetables, 30% subsidy. Okay, great. But could you give a 30% subsidy on red meat? I guarantee you'd get similar, if not better, numbers. We distinguish food as medicine interventions from programs that respond to general food insecurity by being designed or administered with the express purpose of tackling your health concerns. Food banks in the UK are an example of food insecurity. Access to food banks sometimes requires a referral from a healthcare provider, but the food received is not tailored or appropriate for people living with a specific health condition. By contrast, at a preventative food pantry in a hospital in the US, a hospital dietitian reviews the patient's medical records before selecting a mix of shelf-stable and fresh foods that are nutritionally appropriate for that person's condition. Given what we know about the impact of food insecurity on individual health and healthcare systems, 2,526 programs like the UK's food bank voucher system, the US Supplemental Nutrition Insurance Program called food stamps, and Brazil and Mexico's conditional cash transfer programs are likely to provide some protection against adverse health outcomes. But the support they provide is not coordinated with the healthcare system, so specific health impacts can't be measured. Innovations that include clinical evaluation, clinical guidance, financial support for food when medicine intervention or food as medicine interventions in the healthcare system might be effective and an expedient way to improve both the food insecurity and their health, even if they do not comprehensively tackle the root structural causes of suboptimal diet. And this is part of the issue, you guys. A lot of chronic disease happens because people can't afford to get the foods that they need. So then what do? They go to the store and they look for what's on sale. What's usually on sale is the crappiest of crappy garbage. I can tell you, when I was much bigger and much more unhealthy, I would literally go to the store and didn't care about what I ate. I literally would go to the store and I would look for the things that were on sale. And I would go to like the frozen food section and I'd look at the, Hot Pockets. I'd look at, frozen pizza. I would look at, everything. I would look at like Little Debbie snack cakes, and if there was a big sale, let's say Little Debbie, they had 10 for $10, I would get 20 boxes of Little Debbie snack cakes. Oh, that's $20, and that's a whole lot of food for $20. So in my mind, economics is what got into my head. And there's a lot of people that were even worse off than I was then when I was doing that. And so they make those choices. Whereas if you told them, okay, we're going to give you $50 and we want you to spend money on stuff for $50, and you educate them, okay, if you get these foods on this list and here's $50 to go do it, and it's going to help you with your diabetes, who wouldn't do it? Now, obviously, you'd still have some people that would probably try to abuse the system, but most people just need that education, and they need to be given the assistance. And that's not something we talk about enough in this conversation of food as medicine. In the U.S., government and private health insurers are adopting food and nutrition interventions in the hope of a return on their investment due to reductions in the high costs of healthcare. In light of emerging evidence, and policymakers are experimenting with loosening the parameters of value-based or capitated payment structures to allow public insurance money to be spent on food as medicine interventions. Guys, insurance companies have everything to gain by embracing this kind of an effort. I have been shocked. I mean, literally shocked. If you are an insurance company, don't you want a bunch of healthy people buying insurance? Because if people are healthy, guess what? You ain't paying claims. And guess what happens when you don't pay claims? You make a profit. And when you make a profit, you're able to keep expanding your programs. And when people need you, you're there. But if people are healthy, so why don't you reallocate some of that money that you've been paying out in claims, reallocate it to helping to pay for good food and helping to set up the infrastructure so that these food as medicine modalities can be implemented. Yeah, it might hurt you in the short term if you have to start paying for those things up front. But think of all the money they save on the backside, not having to pay claims because people got their health better because they changed their nutrition, right? This flexibility can be expanded administratively or through legislation to all public health insurance programs. Large-scale uptake of newly created flexibility to pay for food depends on confidence that food as medicine interventions are clinically effective and cost-effective compared with other aspects of medical care. You know what I wish they would do? If they want to prove the efficacy of food as medicine, they need to contact all of these doctors in the paleo, keto, carnivore movement, real food movement, who are already using this with their patients. Because they have clinical data. They've been looking at patients, they've been following charts. All they did was change their diet, getting them off of medication, seeing improvements in type 2 diabetes and heart disease risks and cancer and on and on and on. All they have to do is look at those charts and they could make a nice little study. I would love it if some researcher could take that upon themselves and say, okay, we want to implement food as medicine, so let's look at all the doctors who are using food as medicine in their practice. Let's take a look at their patient profiles and let's do kind of a epidemiological kind of research paper looking at all that data and coming up with findings. That does not seem like it would be that hard if you have doctors that would be willing to open their patient books. And I don't know anybody in this space, medical doctor, that would not want to have that data published. The problem is these doctors in their day-to-day are seeing patients. And so they're seeing patients all day long. They don't have time to do this research themselves. But you got this doctor here, it's got this doctor here, this doctor here, this doctor here, and they've got a wide variety of patient populations. I know one very prominent keto doctor has a mostly African-American population of older women primarily. I've got another doctor that's got a primarily white older population as their patients. I got another medical doctor in this space who sees a lot of athletes in their practice. So, I mean, you're going to run the gamut of just about every type of person, and you can see the efficacy of what food as medicine looks like in the real world. We don't need a fresh randomized controlled clinical trial doing this. take all that patient data. Some of these guys have been practicing for well over a decade, and let's take a look at the outcomes. Would be really cool to see. So what are the benefits of food is medicine? Referring patients to food is medicine interventions can change their ability to follow the recommendations, tackling several barriers to healthy eating, including the inability to afford or access the foods. Providing food or food-focused financial assistance can alleviate budget constraints that prevent patients from affording medications and paying bills. That's the thing. If patients can't afford medications, they help them. They help them. So if patients can't afford these foods that would make them healthier, why can't they apply the same principle? And I would dare say they could probably get help buying the food, and it'll be a whole heck of a lot cheaper than the help they get from the medications. Somebody's paying those pharmaceutical companies because they're making hand over fist money. Some food is medicine interventions model appropriate portion size and ingredient selection, enabling participants to maintain more healthful diets past the intervention. Clinicians who refer patients to food as medicine interventions might also see better disease management and fewer admissions to the hospital. A patient with diabetes who typically runs out of food when their monthly assistance is over could be given anticipatory nutrition guidance and vouchers for supplemental food so they don't go into hypoglycemia. I wonder if those patients in that situation could learn to implement maybe an alternate day fasting protocol so they don't get to the 22nd of the month, they're out of money, they don't have any money to eat, and so they just fast. But then maybe they have some junk, and so they're eating a little bit of junk, but that's making their blood sugar spike and then crash, and they're getting hypoglycemia that way. Whereas if they took the same amount of food that they ate the first 22 days and instead maybe fasted every 3 days. So eat, fast, eat, fast, eat, fast. They would stretch that money out. But again, nobody's talking about that as an intervention either. So how do we integrate this into healthcare? Healthcare systems are a logical delivery or connection point for food as medicine interventions, but integration depends on many factors. We discussed the need for additional data on effectiveness of these interventions, including increased clinician knowledge and familiarity, as well as funding. We need more data, they say. Most studies to date are quasi-experimental or small short-term pilot interventions. Key evidence gaps include the comparative efficacy of different interventions on physical, social, and mental health outcomes, healthcare utilization, heterogeneity of treatment effects, which one works best with which groups, defined by both clinical and social circumstances, optimal intensity and duration of the intervention for different situations, and given that the interventions might have effects throughout their life, the appropriate time scale to assess the benefits should also be considered. All fabulous questions because we don't have that data as we speak. Now, people are living that data, but they don't necessarily have it in a setting, in a research setting. Supportive evidence can be derived from careful modeling and micro-simulation studies to forecast and compare dietary health and utilization and cost benefits for different interventions and scenarios, both over the short term and the long term. The promising findings observed in studies to date must be evaluated with larger implementation studies, including randomized trials that would give those appropriate comparisons. These might not always be feasible because nutrition research questions often involve long time frames with treatments that might be difficult to standardize. Instead, quasi-experimental designs with low risk of bias can be used when appropriate. These include analyses of natural experiments, instrumental variable analysis, regression, discontinuity studies, interrupted time series approaches, and difference in difference designs. Don't get bogged down by that. It just means they need various ways of looking at this so that they could come up with what the best strategy would be for the patient. For food as medicine interventions to be most effective, the participants should be engaged and their experience evaluated. In other words, a lot of even the studies of nutrition, those patients, they look at what's the dropout rate and compliance to the diet, because those are keys If you put somebody on a diet they don't want to be on, how compliant do you think they will be? Not very. And so coming up with an effective one means that the person needs to be engaged and want to do it. And then evaluate, okay, how'd you like it? And then what are you getting as the outcome? Qualitative research will better integrate individual perspectives into the design of the Food as Medicine program, and they'll reveal how, why, and in what context they work best for the participants to tackle historical mistrust of the healthcare system and ensure cultural appropriateness of offerings. Research to integrate food as medicine services into healthcare and bring them to scale should contemplate co-design of interventions with the eligible participants and the community-based organizations. So, one of the challenges here are trying to improve clinicians' knowledge. They should be knowledgeable enough to recognize what a patient's nutrition needs are and understand the potential impact of available services, but this is not the case in many countries. In the US, for example, healthcare professionals other than an RD gets very little or no food and nutrition education. Less than 1% of lecture hours are spent on nutrition education in medical school. Can I tell you what a travesty that is? 1%, less than 1%. And it's much less than that for a lot of them. And yet, how many parts of your health have everything to do with the food you're putting in your mouth? A lot more than 1%. To me, if they made half of medical school nutrition education and the biology of what happens when you eat said food goes in the body, what happens? If they would go through that process and they would say, okay, for this person with this disease and this, how educational would it be? And that right there, to me, is the flashpoint of how you get food as medicine to become a reality. It starts in the medical school. If they're not learning how to do this early, how do we expect them to do it when they're in clinical practice? An assessment of medical nutrition education initiatives in 6 countries outside Europe, 15 in Europe, found that nutrition is insufficiently incorporated into medical education in every scenario. Numerous recommendations have been made over the past 2 decades to advance policies to increase that nutrition education, but change remains elusive. Wait till you find out why. Theories about the lack of progress include a lack of leadership. These medical schools, they don't give a crap about it. So if you don't give a crap about it and you don't have any leader that's trying to push food is medicine, why, pray tell, would you think they would change and start teaching it suddenly? And so they don't. Faculty level nutrition champions at medical schools, there are none. And if you get in on a factory level medical school job, you want to keep that job. You want to try to go for tenure. You're not going to raise a stink and say, hey, I think we need to be teaching more nutrition. No. Especially, and here's the wrinkle in all this, guys. Food is medicine cannot become predominant until pharmaceutical companies stop having their grubby hands so heavy in medical training. There, I said it. A lot of people won't say that out loud, but they are the reason. And I've been to many a medical conference with what I get to do for a living. I've been able to attend a lot of medical conferences to hear some of the latest science. And I can tell you, the pharmaceutical companies are basically lurking all over the place at these conferences. From having a booth that sells the next greatest drug for controlling your appetite to being sponsors of the breakfast. So they'll pay for this breakfast and all you got to do is sit through one of their boring lectures about their latest drug. I sat through one time just to kind of hear how they manipulate these doctors. Well, you know, if you're having trouble getting that patient to lower their blood sugar, this drug is going to do it like a champ. You can get your reimbursement from the doctor or from the insurance company and blah, blah, blah. They were selling it hard. And I'm going, oh my gosh, this is so skeevy. And that's a big problem. A lack of compelling training opportunities, such as fellowships that focus on nutrition. These doctors going through medical school, they don't have that. Rapidly advancing nutrition science, That is a big one as well. But rapidly changing and advancing nutrition science should not mean you don't have a basic understanding of nutritional health. To me, did I learn everything when I went to college? Did I learn everything I would ever know about the subject I was in? No. But I laid the foundation of the basic principles of that subject, and then since then have been able to add to that through additional study afterwards. The problem is the doctors aren't even getting that initial information from medical school. Give them the groundwork, the basics, and then they'll continue on after they're out of medical school. And then finally, rampant public nutrition misinformation that might have minimized the perceived credibility of nutrition science among physicians. So this is where a patient comes in, well, I heard that if you eat a lot of vegetables, you can ward off cancer. So I'm sure they've heard those kinds of things, and thus it makes doctors tune out nutrition as a medicinal modality. Most physicians recognize their lack of sufficient nutrition education and would like to learn more to tackle this key driver in health. So nutrition training delivered across disciplines hold the promise of more effective patient nutrition education and treatment. Culinary medicine movements are blending clinical medicine with individual nutrition education, focused on the practical aspects of food prep and cooking. This supports a healthcare professional's willingness and ability to recognize nutrition needs and provide appropriate practical advice to their patients. So clinicians should have familiarity with all of these tools in the toolbox, the range of available food as medicine interventions, and those systems. Doctors should also understand the role of and collaborating with dietitians to appropriately treat people who are at nutritional risk. This is another part, guys. Doctors basically punt to the dietitians when it comes to anything about nutrition. And we know dietitians put out some pretty crappy advice. So this is going to be a challenge getting this food as medicine message out there. Is what's going to be taught? What are we going to say to patients? Is it going to be this carte blanche across the board, low fat, high grains that's typical? Or are we going to actually customize it to that particular condition that the patient has? All right, let me skip forward because we're running out of time. Sustainable funding in and out of healthcare. The food as medicine interventions up until now have all been funded by philanthropy and thus vulnerable to downturns in charitable giving and time limits on grants. The absence of a sustainable funding mechanism means that in many locations, these services might simply not be available. Thus, a widespread implementation of food as medicine interventions, particularly delivered through or with the healthcare system, requires financing models that consistently support these services. Sustainable support could be raised through public or private healthcare money and other government funds. Healthcare dollars pay for interventions such as enteral and intravenous feeding support and supplements, but payment for food and meals is often allowed only in the very narrowest of circumstance. For example, an inpatient assisted living facility or nursing home patient could get help for their specific nutritional items. This restrictive strategy might not be wise. In the U.S., an individual can get 7 months of medically tailored meals, nutrition counseling, and case management for the average cost of one inpatient hospital admission. Because many of these interventions are provided in an outpatient setting, trends toward shorter hospital stays would not decrease the efficacy. So that's a challenge as well. All right. They've got some examples of how this works. They looked at Massachusetts and California, and that they've shown efficacy there. Future directions. The integration of food as medicine in healthcare depends in large part on new investment in research to add to the evidence base. So they've got decent evidence now, which they've outlined in this paper, but they're saying a lot more full, extensive research into this would be very helpful. So my idea earlier, go look at all these people already using food as medicine in their own practice. Somebody take all that data and then come up with a research paper. That would be very compelling. Improved clinician training and referral capacity together with increased financial support for interventions will help to ensure that patients are assessed and referred to appropriate interventions available in every community. Access to these interventions will be supported by organizations and entities that can deliver the food and nutrition interventions, some of which can be complex. In the U.S., for example, a number of nonprofit and for-profit entities are contracting with the healthcare system so they can provide these services, many of them for the very first time. And so COVID-19 has brought the fragility of the food and healthcare systems together, skyrocketing rates of food insecurity, people with diet-related illnesses struggling with increased barriers to getting that healthy food. So this is an idea, you guys, that they're trying to finally put food as medicine on the map. And again, I say it's about time. Welcome to the fray. We've been trying to get you to talk about this and put this on the radar screen of medical doctors for a long time. But let's not pretend like this is going to change overnight. This is something that's going to take years to implement, because people are so used to, and this is the other wrinkle in this discussion, patients have become accustomed that when you go to see the doctor, you're not going to go get diet advice, you're going to get a pill. Doc, I've got a pain in my left side, and I think it's this and this and that. Oh, you got diabetes, you got this, and here's a pill. Oh, and here's a pill to help cover up the effects of what that first pill will do. Oh, and here's another pill that will cover up the pill that was covering up the effects. You see where I'm going here? And so that's what people have become accustomed to. Just give me the pill, doc. And so we've got to break that mold that the pill is not the first choice when it comes to your health. Making food is medicine, the primary modality for treatment of X disease, should become the norm. And that's going to take years of undoing the indoctrination that the medical system has put on us, telling us that every bit of your health is found in a medication. Those days, you guys, I think are long gone. All right, let's see what you guys have to say. I'm going to first come over here to Instagram, then over to Facebook, finally over to YouTube. Thank you all for being here today on Jimmy Rants. See what you guys have to say. JimmyRants.com is the website, as always. Go check it out. Ambi says, read Deep Nutrition by Kate Shanahan. Supports this idea. Yeah, Kate's a good friend of mine. I'm working on getting her on my podcast, the Live and La Vida Low Carb Show, very soon. So, yeah, stay tuned. We will have an interview with her. But yeah, she's wonderful. Deep Nutrition is definitely an amazing book along those lines. Rachel says, I'm late. Well, welcome, Rachel. I'm glad you were able to make it. All right, Instagram, thank you for that. Let's pop over here now to my Facebook page. What's up, Facebook? See what you guys have to say on this one. You guys got nothing. Wow, you guys, you either stunned into silence today over a paper that actually is pushing food as medicine, or cat's got your tongue. All right, let's see. I know YouTube always comes with the A game of lots of comments, especially when my bud Edith is here. She always writes me a book. Edith says, everybody wants the drug to escape responsibility and themselves. I know all about those plans. They're pocket murder. What about prepared packaged meals like Blue Apron? We've become the 80s all over again. Now, instead of Weight Watchers, Lean Cuisine, and Le Menu, we've got Blue Apron, Butcher Box, and other stuff. Anybody want to punch Ansel Keys? I know he's dead, but forget about it. You are hilarious, Edith. I love you. Craig said, did I hear you list fiber as essential? No, you did not. You heard me list fiber as part of what is in carbohydrate, but I never said it was essential. No, it is not essential, but it is a part of the benefits that you get when you eat carbohydrate-based foods. All right, thank you, YouTube. Sorry, Edith, I can't read every one of your comments. You literally write me a book, so I love reading your commentary, but I can't read all those on the air. She literally had like 10, 12 comments, guys. So she's excited to watch Jimmy Rants, and I really appreciate you watching too, by the way. All right, let's see if there's anything else over here, and I see nothing. So guys, food is medicine. This is big. This was actually published in the British Medical Journal. They've been doing a series called Food for Thought in 2020. And so go check out bmj.com if you want to read some more of those food for thought articles. But this idea of food is medicine, it's catching on. And we're realizing this. And I think a big revelation in here was where medical doctors are realizing, we don't know anything about diet. My patients keep coming in and telling me about this keto thing. I don't know what a keto is. And of course, people are shocked by that. Oh, I go see my doctor. He didn't even know what the ketogenic diet is. He just tells me it's dangerous. He doesn't know what it is, but he tells me it's dangerous. What's wrong with that picture? But it's encouraging, and I hope you're encouraged here today that food is medicine is on the way. That's it for this episode of Jimmy Rants. JimmyRants.com is the website. And as always, you can engage live in the content. You got to go follow me right here on Instagram. I am at Living Low Carb Man, LIVINLOWCARBMAN. Once you're there, engage live at 11 a.m. Eastern Time, Monday through Friday. That's when we're here. So go check that out. You can also see us, and we simulcast live over on my Facebook page as well as on YouTube. So thank you all for being here today. If you missed the live, we do have it on IGTV. So go check it out on replay. We also have it on replay over at YouTube. Type in the keyword Jimmy Rants. You will find the show. Today is the episode of Living La Vida Low Carb show today. Has a best of Jimmy Rants. So go listen at llvlc.com. And then finally go on over to jimmyrants.com, the official website. You can see all the past episodes. While you're there, click on the Patreon link. We are starting to add fresh content. And guys, stay tuned. If you are one of my Patreons, I am going to start doing exclusive videos just for my Patreons. And so you also get to determine what we're going to talk about. So really excited to get that going here real soon. Thank you so much for being here today. Really love doing this show. And I hope you enjoyed as much as I enjoy delivering the content. So thanks for being here. We'll be back again soon. Bye.